Hi, my name is Dr. Bill Young, and I'm talking today about hemiplegic migraine and migraine with unilateral motor symptoms, or MUMS. So what I hope to get out of this talk is to explain what an aura is by its definition, explain what is wrong with the definition of an aura, explain what is going on in the brain with a typical aura, describe the typical symptoms of hemiplegic migraine, show that there are many neurologic symptoms that may not be aura, even if they fit the definition, show what the symptoms of MUMS are, and show how these symptoms may be confused with hemiplegic migraine. So first of all, here's the background. The world of headache medicine and neurology has divided the migraine attack into a number of phases. For hours or maybe a day before a migraine headache attack, there can be prodrome with changes in mood or appetite. People can get irritable, occasionally elated, and these are just signs that a migraine isn't coming. And then there's an aura, which is said to last from 5 to 60 minutes, realistically about 30 minutes, with some neurological changes that are related to a specific part of the brain. And then there's the migraine headache that comes with the neurologic other associated features like nausea or light and sound sensitivity. And then at the end, there's the unusual feelings that people have as the attack ends, even though the pain and the light and sound and the sensitivity and nausea are gone. So that's a complete attack. This kind of well-ordered progression of symptoms from the beginning of the attack, even before the headache or the aura, until the headache and the associated symptoms are gone. So that's how we kind of look at a migraine attack. So what's an aura? An aura is reversible neurological symptoms, most typically visual symptoms. And the most common kind is called a scintillating scotoma or fortification spectrum. And sometimes there's numbness or tingling, or other symptoms of aura are much less common, like weakness or language disturbances. And here's the definition that people gave to diagnose aura. So visual, sensory, speech, language that are reversible without motor symptoms, brainstem symptoms, or symptoms that come from the retina of the eye. In fact, in just one eye, that's not a typical aura. And the symptoms spreads gradually over more than 5 minutes, but there can be a couple of symptoms in succession. So you can have a visual aura followed by a sensory aura, followed by a language aura, and each symptom complex, each symptom type lasts less than 60 minutes. And at least one of the aura symptoms has to be just on one side. So, it's not really normal to have, or according to this definition, to have aura going on at the same time on both sides of the brain, which is where auras come from. And generally, an attack of headache pain comes with the aura or comes within 60 minutes of the aura ending. And it's not caused by something else, like a stroke. And here are some pictures of a typical visual aura. You can see somebody whose vision is impeded while they're driving. The one on the top right-hand corner is a famous physician from Boston, and he recorded his aura over 10 minutes, and you can see how it's kind of moving away from the center of gaze. and it is growing and expanding, and it has this kidney bean shape. Another famous aura from history from the 19th century is the one on the bottom left. Again, showing the beginnings of the aura, that little thing in the middle, and how it expands out, and how there's sort of a loss of vision in the central area. And then for this person, and for many, there are these lines that sort of repeat and fade away. These can move or scintillate or shimmer. And then the last one was by a famous nun who used to get these visions, which we think were auras, followed by, these incredible headaches. And she described these auras or explained them as, visions from God. But you can see these repeating lines with a central loss of vision. This is from the 12th century, I believe. And then sometimes aura is sensory, and like the visual aura spreads over time, the sensory aura usually starts in the fingertips, but it can start somewhere on the body, most typically hand or finger, and then it goes up the arm. It sort of crawls up over like 5 to 60 minutes, and oftentimes it jumps onto the face, and the face on one side, on the side with a numb hand, gets numb again, usually on one side of the body. But there are many other kinds of interesting things that are or have been called auras. Smell auras, taste auras, feelings that something's unfamiliar, or feelings that something is familiar, but you've never actually seen it. Feelings of delirium, of alertness, and these can be, these 5 to 60 minute episodes that that occur in relationship and near the beginning of a migraine attack. And one of the really interesting ones is called Alice in Wonderland syndrome, where there's a sense that the world, the disordered perception, and things are out of shape. People may see things that are close that look far away, or they're twisted or bent, or you feel like you're in a fun house. Or alternatively, it's not something you see, but you feel like your own body is misshapen or misformed. And that's called Alice in Wonderland syndrome. And the most common cause of that is migraine aura. Migraine aura is a thing that's happening on the brain, and I'll show you more. But these were a few cases of very complicated neurological symptoms, but the doctor was able to trace the parts of the brain where each symptom, as it developed over time and faded away, happened, and trace this pathway of this abnormal brain activity as it spread across the surface of the brain. So aura is really a thing that we think is happening on the surface of the brain. This is what we used to be taught, and this is what you'll hear still sometimes by those who have not kept up with modern thinking, that aura is caused by constriction of blood vessels in the head, and the headache is caused by dilation. And it turns out that while constriction and dilation of blood vessels does occur, it's way outside of, it's in the wrong time frame for explaining the aura or explaining the headache. And the constriction occurs before and after the aura, and the dilation occurs after the headache has started, and continues on long after the headache is gone. The changes in the blood vessels are more or less incidental things, and they don't have anything to do with the symptoms of migraine aura. What's causing it is cortical spreading depression, which is this electrical wave that's traveling slowly across the surface of the brain, and you can, you can see in the symptoms the progression of that wave of electrical activity and inactivity as it happens on the surface of the brain. And this is what it looks like in a rodent, a cat, actually, so not a rodent. But you can see how the electrical activity goes away in one part of the brain, and it goes away a little bit later in the next part of the brain, and how the same, loss of electrical activity recovers in that same sequential way. So this really is a thing, and they've been able to sort of correlate that, while the brains of rats, are a little bit different or cats, it happens in all kinds of animals with, with smooth brains. More easy to see in animals with smooth brains. This thing really is going on the surface of the brain during what we think is an aura. And you can see this a little bit or something like it going on in the brains of humans. So you can sort of go back and forth between seeing this kind of abnormal electrical activity in humans. It's very hard to see. You're never, you're sort of listening to the brain at the right time. Whereas in a cat, you could start an aura, just when you want it in terms of your experiment. And medicines that control, there are preventives for migraine, many or most of them will reduce the ease at which you can start the spreading depression in a laboratory animal. So you can see if you are starting the aura-like waves in the control animal, it's much slower when they get to pyramide or propranolol or amitriptyline. So the medicines that we would hope would work to suppress aura seem to do so in the animal model of aura. Most patients, you cannot find the EEG changes that you can in animals easily because of the way the brain is shaped, or there might be slight differences in what it looks like in a human type of brain than an animal type of brain. And they don't have the kind of profound neurologic impairment, thank goodness, during an aura that you might expect to see in a rat whose brain stops functioning in a large section of their brain. So there may be several kinds of cellular waves. It may not be just the kinds of cellular waves I showed you in rats, but there may be similar but slightly different ones among different types of cells in the human and in the experimental animal. But very lucky or very special or rare occasions, every once in a while, you can see these cortical waves in humans. That when they just happen to be in the doctor's office, or they have some very, very powerful auras, they might actually get temporary changes in an MRI that follow a very strong aura. And that's what's shown in the bottom right-hand corner. And here's some other examples, where there are brain changes. The study on top is a PET study. It would probably happen if you were happen to be doing a study of somebody having an aura with a PET scan. You could probably see it in everyone. Other ones, changes on the CAT scan, which is what you see on the right, are very rare, even though thousands of people have been imaged during their auras. You only very rarely can see any changes on the CAT scan during the time of the aura. And of course, everything in an aura goes away once the brain gets back to normal. Now, there are other things that people talk about, which are late life migraine accompaniments, which can look like, have similar properties to auras, but we really don't know what causes them. And there is no way to talk about them if you're studying classical headache medicine. And yet these things happen all the time. About 5% of people who go to the ER for a stroke actually have a migraine. And these late life migraine equivalents, which generally don't have any headache or much of a headache that follows, have often visual symptoms, but may not, but they do grow or expand, or they can spread. The numbness can spread like an aura. And there's often progression of one type of symptom, like a visual, into another, like a sensory or a motor. And there can be the same type of spell happening over and over, just like an aura. And a headache may or may not come, and typically attacks episodes. Each part lasts for 15 or 20 minutes, and they tend to sort of cluster. So people may have a bunch of these over a few days or a week, and then not have anything for a year or two, and then have another little cluster of auras or late life migraine accompaniments. And then you need to not be caused by anything else. So let's talk about hemiplegic migraine. And hemiplegic migraine, plegia means weakness or paralysis, and it's got fully reversible motor weakness. So people become weak or paralyzed on one side, and some other kind of sensory symptom, like a visual or language or speech problem. So, that's a hemiplegic migraine when one of the components of the aura is weakness. And if it runs in a family, if somebody has this and a first or second degree relative has the same thing, then they have familial hemiplegic migraine. And there are 3, and some people think there's a 4th type of familial hemiplegic migraine. I, of course, won't go into all of this, but all of them raise glutamate, which is the excitatory transmitter for the brain, and the levels and the function of glutamate are just a little bit out of whack and a little bit high. And that's thought to be, the basic thing that's wrong in familial hemiplegic migraine. So familial hemiplegic migraines typically starts in adolescence, 12 to 17 years old. It's very rare. Girls and women are more affected than men. It's migraine after all. Its frequency and severity get better as you get older. The weakness is on one side, and very rare to have bilateral weakness. Occasionally it'll switch sides. You'll have one attack where one side is weak, and then the next time it's on the other side. And there's, well, by definition, but also practically, often one or more other aura symptoms, as I mentioned, sensory, visual, language, and less common, vertigo, clumsy walking, and some other ones. And very rarely people have fevers or seizures or even coma as a symptom of familial hemiplegic migraine. And there are some forms of hemiplegic migraine where people develop, progressive brain abnormalities. One of the types in about half the patients, but most people don't have any kind of progressive neurological deficits. They just have these attacks. They're very severe. They recover and they're back to normal. And you can sometimes see this is another sort of MRI change during a migraine, familial hemiplegic migraine attack. And they are showing these doesn't happen every time you have an attack. And, people and it recovers, it's reversible, just like the aura. Now, sporadic hemiplegic migraine is just like hemiplegic migraine, except there's no family history. Nobody else in the family has it. You like for non-hemiplegic migraine, you have to have some other symptom. It can be more abrupt. It can, present, like a stroke or coma, and the neurologic exam can be abnormal. So I'm going to talk to you about something else. A patient of mine who was 62, and she started having migraine with aura in her teens, and it went away in her 40s. And 5 years ago, for 5 years before, I made the slide anyway, she developed another kind of headache in the back of the head with other symptoms of nausea like light and sound sensitivity. And then once the pain started, she would get numbness in her face that would travel to her arm and leg. And simultaneous with this, she would develop weakness in her left arm and then her left leg. And after the weakness and the numbness, which came together, she would have trouble speaking and slurred speech, and she'd get a droopy eyelid. And through this, she had terrible nausea and vomiting and light and sound sensitivity, and scalp sensitivity, and a stiff neck. And she had, many attacks. The headache would resolve in a couple of days, and the weakness would persist. So she had 27 episodes, we think, by the time she saw me. And she would typically get 17 times she got hospitalized for a stroke. And she would go to rehab afterwards because it took about 2 weeks of rehab before her hemiplegic episodes, her weakness resolved. And so she had 17 of these. She'd been told that she was having strokes and that, she couldn't take all kinds of migraine medicines. So the weakness persists. And she had a normal exam, except for, some kind of giveaway weakness, which, is usually not what's caused by hemiplegic migraine or a stroke. But her movements were slow. And her imaging was completely normal. And she was one of the ones that made me think that, maybe this is not the same thing as hemiplegic migraine. The pain came first, and then the numbness and the weakness were together simultaneous. It's supposed to be split apart. Those parts of the brain are in different places, numbness and weakness. And if this thing is traveling, it has to be first usually on the numb side of the brain, and then jump over and affect the strength part of the brain, the feeling part, and because they're in different places, the strength part. So, I began to study these, and in one summer, I parked a medical student in our office, and I found 24 people who had normal MRIs, who during their severe migraine attacks, they got weak on one side, and they were almost all the same. They had this pattern of onset where the numbness and the weakness came together, usually unlike migraine with aura or familial hemiplegic migraine. It started in the face or neck, transferred down to the body, but they had lots of symptoms, visual symptoms, language symptoms, confusion, many neurologic symptoms. And the weakness in MUMS could last any length of time, from 5 minutes to more than a week. So we looked at patients with equally severe migraine, and we wanted to see what the difference was between people who had very severe migraine and people who had MUMS, all of whom had very severe migraine attacks. And what was the same between the two were a whole number of things, but what was different was a lot of the symptoms in in people with MUMS, with this one-sided weakness, were more severe, so more light sensitivity, more nausea, particularly more scalp sensitivity, as well as more a lid drooping and eye redness and tearing on the side of the headache. So all of these things were like a super migraine. So, I asked the question, so what are the differences? If MUMS is something different than hemiplegic migraine, what are the differences? Well, MUMS starts in grown-ups. The average age of onset was 37. And for hemiplegic migraine, it's reported to be teenagers, as I told you. The order of symptoms was generally different. Most people with hemiplegic migraine get a typical visual aura. And just as that's stopping, they get the sensory aura. And then they get the motor aura or the aphasia. And then if they're going to get dizzy, they get, or their brainstem aura, they get that. And you can think it, you can almost see in their brain that organized pattern, one part of the brain, then the next part of the brain, and the next part of the brain. Whereas in the MUMS patients, it was much more variable. It was usually the same for the same individual, but it felt more like an avalanche. So, they get a little bit of a visual symptom or some numbness, and then the whole thing would rapidly come on, the numbness and the weakness and all the other symptoms. And often the first thing was the pain. The headache preceded, in the vast majority, the most common first symptom was migraine headache pain. Again, very heavily weighted towards women. But like an aura, most of the people with MUMS had this sort of, the numbness and the weakness started in one place and it traveled on the body. Whereas familial hemiplegic migraine, almost everybody has that. So this was kind of similar, but this kind of pattern on the body of the symptoms spreading, was present, but not as strong in people with MUMS. Let me talk a little bit, no slides now, but just talk a little bit about, what I think MUMS is and how I think it should be treated and addressed. I did this study, maybe 10 or 15 years ago. If you look for it as a headache doctor, you'll see it often. And smart patients who don't want to be disrespected or stigmatized sometimes hide it. Like I've heard a patient say to me, yeah, when I get a migraine attack, I'm going to carry the milk on the other side of the body, not the headache and weak side of the body. But I don't want to mention it to my doctor because they're going to get a CAT scan and I know it's just a normal part of my migraine. But sometimes the weakness is too much and they can't ignore it, or legitimately, it scares them. Over time, my approach has become this. Like, this is a super migraine, and the weakness is one of your many symptoms of migraine. It is probably not the same mechanism as an aura. It's probably going to have, respond to things that treat the migraine headache. You need to be super aggressive. There is no additional risk of stroke or problems for having MUMS. All this, this hooey about you can't have a triptan or you can't do this or that because you have hemiplegic migraine, is just wrong. And especially wrong for patients with MUMS. You need to treat it quickly. I want to go back to that patient I told you who was hospitalized 17 times for stroke, but had MUMS. I taught her how to give herself a shot of compazine for migraine headache. Compazine works for migraine headache. And while she had attacks afterward and eventually, preventive stopped her migraine and her MUMS attacks, they were never as severe when she started to treat her migraine attacks adequately. She never got hospitalized again. She might have attacks with a little bit of weakness, but she recovered much more quickly, and she went on to have a very normal life. So, I think that headache medicine has lost its way a little bit. It's kind of ignored a lot of symptoms. The only category it gives us is the category for aura. And on the one hand, if aura is anything that's reversible and an interesting neurologic symptom that happens with a migraine, it doesn't mean anything. It's like, it's just a symptom that means that it's a symptom of migraine. If it's something that's caused by spreading depression, then many interesting, important, and life-changing symptoms that people with migraine get are not being studied, they're not being diagnosed. I think MUMS is only one of several symptoms that our patients are telling us that they have, and we're not listening, and we're not studying the best ways to treat this other kind of thing that happens to people with migraine. Thank you.